Hi, everyone. Welcome to the ICA's monthly speaker series, Navigating IC BPS Conversations with Experts. We are delighted that you are here with us today to learn from Dr. Jill Peters, board certified urologist and member of ICA's Medical Advisory Council. Before we start, I have a few housekeeping items. Please note that this session will be recorded. If you are on camera, your video will be included in the recording. We will have a Q&A session following the presentation. To ask a general medical question throughout the session, please use the chat feature. Once the Q&A session has started, you may also use the raise hand feature in Zoom. You will be asked to unmute yourself. If you aren't speaking, please be sure to stay muted. Dr. Peters will answer as many questions as she can during the webinar. And finally, please complete the post-webinar survey. A link to the survey has been posted in the chat. It is time to get started. Without further ado, please welcome Dr. Peters.
Hello, and thank you for that kind introduction. I'm going to go ahead and just share my screen to get started here. And just give me 1 second. Okay, I believe everyone can see the screen. Today what I want to talk about is understanding IC and bladder pain syndrome phenotypes. But first, let me just introduce myself a little bit more. My name is Dr. Jill Peters-Gee. My patients have always called me Dr. Peters, but it's Peters-Gee. I'm a urologist. I graduated from the University of Michigan back in 1985, and I have been studying, researching, doing clinical trials, and most importantly, caring for IC patients for well over 30 years. I retired from clinical practice in late 2022, and at that time I started the Connecticut IC support group, which I continue to facilitate. Most of the information that I'm going to be talking about today is available on my website, which is www.icjourneytowellness.com. And if you have any questions that I didn't clear up, please feel free to reach out to me at my email, drpetersgee@icjourneytowellness.com. So what are we going to cover today? First, I want to go over just what is a phenotype. Next, we'll go over why it's important to understand interstitial cystitis and bladder pain syndrome phenotypes. How can you use the information to optimize your own therapy? And then we're going to kind of change gears and talk about associated conditions and why do they matter? And then lastly, how do you get started? So just what is a phenotype? A phenotype is basically a description of a smaller subtype within a large group. So let's just say we had a mob of people, and I pull out all the red-headed, curly-haired women and make a smaller little group out of that big mob. That's a phenotype. I'm using certain characteristics to define that smaller group. Now, in interstitial cystitis, we use phenotypes to break apart a very big group into smaller subgroups. And it's important because by looking at the smaller subgroups, we can start getting at what the root cause of symptoms might be. And by learning about those smaller subgroups, we can use that information both from a research standpoint, but also to help guide therapy. And we'll go over that a little bit more. So why is this all important? You know that, when you look at IC as a group, it's this huge group of people, men, women, young, old. Some are sensitive to food. Some might have lots of frequency and very little pain. Some have lots of pain and very little frequency. And the response to therapy is kind of all over the place. There's no one treatment, medication that works for everybody. Why is that? It's because there's smaller groups within the big group that may have different reasons for their symptoms. Most clinicians and individuals kind of use a trial and error approach to treating their symptoms. This can be, take time, it can be costly, and sometimes the therapies that you try could even make you worse. One of my patients likened this to throwing spaghetti up against the wall and kind of seeing what sticks. We want to get away from that approach to treating IC. By looking at the smaller subgroups or the smaller phenotypes, we actually have a chance of moving forward with research. There hasn't been an FDA-approved drug or therapy to treat IC in almost 40 years. And part of this is because when we look at the whole group, we don't get enough benefit when we do studies. So if I had a new medicine that was focused on a specific receptor in the bladder wall, um, if I looked at the whole group of IC patients in my clinical trial, you're going to have some people that have symptoms coming from outside the bladder. And so we want to learn how to think about IC as smaller groups so that we can A, move research forward by looking at the proper group when we're doing a study, but also to be more thoughtful and logical about what kind of therapies make sense for each individual. So how does understanding IC, phenotypes help you? Understanding what we know about the different subgroups from research can help patients and clinicians choose the most logical therapy that's going to help ease those symptoms more effectively and more efficiently. There's been a significant amount of research, especially in the past 20 years, looking at these smaller groups. A lot of the research that I'm going to be talking about today comes from what's called the MAP network. Now, MAP stands for the multidisciplinary approach to the study of chronic pelvic pain, basically. And what it is it's unique in that it's using a very multidisciplinary approach to looking at IC more systemically, more globally, and not just focusing in on, what's wrong with the bladder. The MAP network specifically is focused on advancing the understanding of syndrome phenotypes, syndrome etiology, what's causing the symptoms, and the natural history. And it's not looking at just IC and bladder pain syndrome. It's also looking at chronic prostatitis and chronic pelvic pain syndrome in men. So we're going to talk about the MAP network throughout this talk. There is a website here, mapnetwork.org, and a lot of, if you just go there, they have all the publications that are coming out and all the most current research on these smaller subgroups and what we're learning. So just what do we know? We now recognize that the symptoms of IC or bladder pain syndrome, and I'm just going to use the term IC because it's less of a mouthful to say over and over again. We know that the symptoms of IC can come from the bladder or the urethra, from outside the bladder, which includes muscles, the fascia, which is kind of the leathery coating on the outside of the muscles, as well as the nerves. And it can also come from the brain or the central nervous system. This is really important because, like I said, for decades, all of the focus has been on what's wrong with the bladder, and most of our research has been focused on the bladder. Now, we've learned a lot from that research. We've learned about the gag layer, we've learned about mast cells, we've learned about the nerve endings, but now we know that for some individuals, the symptoms don't come from the bladder, they can be coming from outside the bladder. So we've really learned a lot in the past 20 years. The concept of breaking down IC into smaller subgroups is really not new. Way back over 100 years ago in 1918, Dr. Hunter described a small group of patients that had ulcers. And today, this is called ulcerative interstitial cystitis. This is a phenotype. It's a small subgroup within the bigger group. And across the world, everyone agrees that ulcerative IC is a unique subset of IC, a unique phenotype, okay? And it's important because the therapy's different. Presentation may be actually a little bit different. ESIC, which is the European Society for the Study of IC, it uses phenotypes, but it bases its phenotypes on the findings of cystoscopy, hydrodistension, and biopsy. Now, we don't use that method of breaking down the large group into smaller groups in the US, primarily because we don't require cysto, hydrodistension, and biopsy to make the diagnosis or to treat, plan our therapy. Dr. Shosky and Dr. Nickel back in 2009 described 6 phenotypes, which is what's called the U-point system. And that system was used in men and women to help break down the bigger group into smaller groups. And that's the basis of the phenotyping that's used by the Canadian Neurologic Society. Dr. Payne in 2015 described 5 phenotypes. The most recent publication was by Dr. Nickel, who's from Canada, Queen's College, in December of 2022, just a little over a year ago. And he described 9 phenotypes. Now, really what he was doing in this paper was responding to lots of phone calls from clinicians saying, how would you treat this group of patients? How would you treat this, cluster of, symptoms, or how would you treat this group of patients? And he basically published a cookbook, a paper that described clinical recipes for success for 9 different groups of people that he would see very often in his practice. Like, how would he address someone that had primarily urethral symptoms, or someone who had an infection phenotype? Now, 2 of his phenotypes were flares, and the other one was pain with sexual activity. Um, I like to think of the phenotypes very similar to how he has, but I think everyone can have flares and pain with intercourse. So I don't include those 2 phenotypes as I go through my description. But the bottom line is um, the concept of breaking up the group into smaller groups has been going on for decades, over 100 years, if you consider Dr. Hunter's description. As I go through what we know about these smaller subgroups, it's important to kind of keep an open mind because most individuals have more than one phenotype. The framework that I'm going to discuss is really based on those past descriptions that have been published by, about the phenotypes, combined with the current research that we've gotten about the smaller subgroups, and then combining that with my own clinical experience taking care of thousands and thousands of patients with IC. Doctors use this when they start coming up with a treatment plan, sometimes without even realizing that what they're doing is they're phenotyping patients. The idea of using this framework is a way of clinically phenotyping individuals. There's no blood test or x-ray that's going to say, yep, you have this phenotype, or nope, you don't have that one. It's a way of clinically looking at findings and symptoms to come up with the most logical phenotype based, for each individual. The one thing that I hope that you get from this is that by you understanding the different subgroups, the different phenotypes, this will help to open up discussions between you and your practitioner, your caregiver, to maybe pursue options that you haven't pursued. So, for example, maybe your doctor has been primarily focused on the bladder, that the source of symptoms must be the bladder. So all of your therapies are focused on the bladder. But when you listen to all of the phenotypes, maybe you'll recognize that you have symptoms of a phenotype that comes from outside of the bladder. So maybe they haven't addressed the pelvic floor. Maybe they haven't addressed the possibility that the brain or central nervous system is involved. Similarly, you may be only doing physical therapy and haven't addressed the fact that you may have a bladder cause of symptoms as well. So use the information to open up discussions with your caregiver to kind of pursue options that maybe you haven't pursued yet. Okay, so we're gonna um, kind of start off very simple. Some people will say that the concept of phenotyping is just too confusing, too distracting, and it doesn't make any sense. I would argue that this is actually very simple. We'll start off with the idea that there's 3 basic sources of symptoms. The first is the bladder and the urethra. So the bladder may be where the symptoms are coming from, or the urethra. You may have symptoms that come from outside the bladder, and outside the bladder includes things like the muscles, the fascia, which is the leathery coating of your muscles, or even the nerves on the outside of your bladder. And then lastly, you can have involvement of the brain or the central nervous system, where more centrally, there's been this upregulation or hypersensitivity that has occurred. So in essence, we have 3 possible sources of symptoms: the brain and central nervous system, outside the bladder, or the bladder itself, or the urethra. This is just another way of kind of starting to break it down. So we have the whole big group as a whole of all IC and bladder pain syndrome patients. We have those where symptoms come from the bladder or the urethra, outside the bladder, or more centrally, including the brain and central nervous system. The first group that you can kind of pull off is those people that have ulcers in the bladder. And again, this is the first phenotype described, and it's pretty easy to know if you have ulcerative IC because you can see the lesions on cystoscopy. So just what do you see? Ulcerative IC is, you can see in an office cysto without anesthesia, and you can see it under a hydrodistension, but you don't have to have a hydrodistension to see if you have Hunner's lesions or Hunner's ulcers. This top picture is an example of an office cysto, and when you have a Hunner's ulcer or a Hunner's lesion, it oftentimes presents with this like little red patch. It's almost like someone's poked you in the eye. It's all red and irritated. In the center, sometimes there's a little ulcer or some mucus or a little crater. That would be an example of a Hunner's lesion or a Hunner's ulcer. Sometimes these show up as more of a whitish patch. Now, down below is an example of a hydrodistension. As you stretch the bladder, and sometimes it doesn't take much stretching at all, the area will just start kind of oozing some blood. It looks like a waterfall of blood coming from these lesions. So it's pretty obvious that you have an ulcer just by cystoscopy. People who have ulcerative phenotype will tend to urinate small amounts both day and night. And you can actually do a bladder diary and measure how much your bucket or your bladder holds. So someone with a ulcerative IC phenotype, as their bladder fills when they're sleeping, they'll start having symptoms. So they'll have a small capacity day and night. Very often they're sensitive to foods. The MAP network has showed us that these individuals sometimes have a more rapid onset of symptoms, and oftentimes they don't have as many of those other pain conditions like irritable bowel, vulvodynia, etc. The MAP network has also showed us that the prevalence of ulcers seems to be more common in men, and clearly is more common as you get older. Their study showed that 4% of people under 50 had ulcers, whereas 20% between 50 and 70 had ulcers, and 55% had ulcerative IC over the age of 70. There have been some other studies looking at it where they've shown an even higher prevalence in the younger age group. One study showed a prevalence of about 9% if you were under 30, closer to 23% if you were between 30 and 60, and again, 55% if you were over 60. Bottom line is if you're male or over 50, it would not be unreasonable to consider a cystoscopy to see if you have ulcers. This phenotype is different than all of the other phenotypes, and it requires a different treatment plan, different therapies than the other IC phenotypes. So it's important to know if you have ulcers. We believe that 10 to 15% of all IC patients may have ulcerative IC. So again, if we go back to our picture, we have all of the IC patients, symptoms coming from the bladder, symptoms coming from outside the bladder, and then from the brain or central nervous system. The first phenotype we pulled off was the ulcerative IC. Now, some people would stop right here and just say everyone else has a bladder-derived source of symptoms. I believe it does make sense to break it down a little further, and just like Dr. Nickel has, you can describe 3 more phenotypes that would be considered bladder-centric or coming from the bladder. The first is the urethral phenotype, and here basically most of your symptoms seem to be coming from the urethra. The second is the infection phenotype, and this group would be people who have culture-positive, documented recurrent urinary tract infections. And then the last group would be everybody else. It seems like your symptoms are coming from the bladder or the urethra, but you don't fit one of these 3. Now, an example of why looking at the smaller subgroups is helpful, if we look at the infection phenotype, for example, in the infection phenotype, they have shown that it appears that the C fibers, which are the nerve endings in the wall that create the sensation of pain or discomfort, seem to be either present in increased numbers or kind of hypersensitive when you've had recurrent infections. You can liken having too many C fibers to a radio where the volume control's been kind of turned up. So if you have a hypersensitive or turned up bladder wall, 3 ounces feels like 10 ounces, and a little bit of pain feels like a lot of pain. This helps us to understand why the infection phenotype has symptoms even when there's no infection anymore. Okay, so by looking at the smaller subgroups, we can start understanding why the symptoms are occurring. Okay, just a good example of why this phenotyping can be helpful. Knowing what we know about the phenotype can then help guide therapy. Okay. Now this, what are the clues that you may have a phenotype that's coming from the bladder or the urethra? And I'm going to keep going back to the clues because I think the clues this is the way that you can help start figuring this out. So it doesn't matter which of the four phenotypes you have. If you have a phenotype coming from the bladder or the urethra, if you do a bladder diary and you measure how much your bucket holds, do you have a 3-ounce bladder, a 10-ounce bladder, etc.? The bladder diary will tend to show smaller volumes both day and night if you have a phenotype coming from the bladder. Most of these people will tend to be sensitive to diet. Not all, but most people will have a diet sensitivity. It's not uncommon to see what we call seasonal flares, kind of during hay fever season, spring and fall, if you live in New England. There may be flare-ups of symptoms, or you may just be kind of a more allergic kind of person. The most important clue is that if you were to put an anesthetic into the bladder or into the urethra, your symptoms kind of get better for a short time. So you can numb up the bladder or numb up the urethra with a lidocaine jelly or a lidocaine instillation, and you may have a little bit less pain or a little bit less urgency. Might not last forever, but at least while it's numbed up, you'll feel a little bit better. That's a pretty good clue that the symptoms are coming from the bladder. Okay. Now, the the second group or source of symptoms would be coming from outside the bladder. Okay. And when the muscles, or we're going to talk about the muscles or the myofascial phenotype, this phenotype includes pelvic floor dysfunction as well. If this is the primary source of symptoms, the clues are different. You may have a better capacity at night. You may not be sensitive to foods. You may find that if you put an anesthetic into the bladder, not much happens. Okay, that's because the symptoms aren't coming from the bladder. Um, you can get what's called a secondary muscle kind of phenotype, and typically we think of this as pelvic floor dysfunction. And here it's more because let's say you had a bladder phenotype and you were having pain and urgency and all the time, and you're walking around constantly feeling like you have to go. You sometimes will almost by reflex tighten up your pelvic floor or kind of clench. And so then when you go to sit down on the toilet to urinate, it's almost like the door doesn't open, and you may develop a secondary muscle phenotype in conjunction with a bladder source of symptoms. The clues that you might have a muscle or a myofascial phenotype would be often you're not as sensitive to diet. Okay, again, an anesthetic instilled into the bladder might not really cause any positive effect. And when we do a bladder diary, you might see that your capacity is actually a little bit better at night. It might be low during the day, but you can hold more when you're sleeping. Oftentimes, with a muscle phenotype, there's been some kind of a history of trauma. It could be you had a pelvic fracture, cracked tailbone, a difficult vaginal delivery, a surgery. There can be something in your past that could have caused the muscle phenotype. Um, Sometimes on exam, there'll be tender spots or little nodules that can be felt in the muscles or the fascia, or actually trigger points, which would be a very tender spot that when you touch it, it's kind of like exquisitely tender and may even reproduce your symptoms. So again, some people may have the muscles as the primary source of their symptoms, but some people may have both. And we don't know what comes first, the chicken or the egg. Do you get pelvic floor dysfunction and then it creates the bladder phenotype, or do you start with the bladder phenotype and get the pelvic floor dysfunction? It's still kind of we're not sure. Bottom line is if you have both, the symptoms might be a little bit different. You might have a smaller bladder and be sensitive to, respond positively to an anesthetic. But either way, if the muscles are involved, you'll tend to have a hesitancy where you have to kind of sit and think about it a second to get the stream to flow. You may notice the flow of urine is slower. You might not feel like you're emptying. Sometimes you even have difficulty moving your bowels, even when you're not constipated. It's like the door won't open to even let the stool come out. The vagina might be very tight and you can't get a tampon to go in. So there are clear-cut clues that you can have a muscle phenotype. It's estimated that somewhere between 85% or more individuals may have a muscle or myofascial phenotype, including pelvic floor dysfunction. Okay, so what's the other phenotype that comes from outside of the bladder? This one, in my experience, is the smallest group. Okay, I've seen the fewest people with this phenotype, and that's the neuralgia phenotype. It's pretty obvious to me when someone has a neuralgia phenotype. The usual cause of this is entrapment or compression of the pudendal nerve, which is a nerve that lies outside of the bladder. Um, Pain is oftentimes a key component. And when I would have patients come in for their initial interview, I would have them sit in a chair across the desk and we would start off the interview. A person with a neuralgia phenotype would oftentimes come in and ask to stay standing. They didn't want to sit down. Or they would come in bringing in like a little donut pillow or a wedge pillow with a cutout because that's the only way they could really sit comfortably. That was a pretty good clue that I was dealing with someone with neuralgia. So as I mentioned, the other clues are that pain is typically a key component, with less urgency and less frequency. Oftentimes, if we look at that bladder diary and see how much the bladder holds, nighttime frequency is not as bad, and the bladder capacity is oftentimes better at night. You may go little bits throughout the day, but you can hold a more normal volume when you're sleeping. Typically, we see foods are a little bit less of a problem. Allergies are a little bit less of a problem. The symptoms are sometimes on one side more than the other side, and the quality of pain can be a little bit different. It may be sharp, it might be kind of zinging, it might be vibratory, it might shoot down your leg or into your butt or, into different spots. Um, Another key clue is that if we put an anesthetic into the bladder, it really doesn't do much, okay? Doesn't help. There's no improvement in the symptoms. Here we also see kind of a history of exacerbating things. Sometimes there's that same history of trauma, pelvic fracture, cracked tailbone, difficult delivery, surgery. But sometimes it's been excessive bicycling, doing a lot of squats at the gym might trigger this. Prolonged sitting might trigger it. People might find that they feel better working at a stand-up desk when they have a neuralgia phenotype. Just like numbing up the bladder can give us a clue that the symptoms are coming from the bladder, if you numb up the pudendal nerve, the symptoms will be better. And we use a pudendal nerve block as part of the diagnostic, the way that we diagnose a pudendal neuralgia. And it becomes part of the therapeutic plan. So the treatment roadmap for a neuralgia phenotype is different than other subtypes. So again, it's important to know if you fit this phenotype. It's interesting in that sometimes when you have horrible muscle spasm, say with a muscle phenotype, that muscle spasm can sometimes compress the pudendal nerve. So oftentimes we see a neuralgia phenotype and a muscle phenotype kind of go hand in hand. And physical therapy is a large part of the treatment plan when you have a neuralgia phenotype. Okay, so the last possible source of symptoms we talked about was the brain or central nervous system. And I'm not exactly sure how to label this phenotype. I called it the brain processing phenotype, but it may be called a central sensitization phenotype, etc. It's really been in the past 20 years that significant insights into the role of the brain and the central nervous system have come to light. It's not clear if this is something that happens over time or if it really starts in the brain. For some, it appears that the pain really starts locally, kind of in the pelvis. And then it seems to become more regional, kind of involving the gut. And then ultimately, it becomes more widespread or systemic. So that's one theory. They have shown that with MRI that you can see specific changes in the white matter of the brain when there's widespread pain. So this is not just like in your head. There's physical evidence that there's changes occurring in the brain when there's a central nervous system component or a phenotype. What we really think with this is that the brain is becoming kind of upregulated or hypersensitive. So very similar to how I described the C fibers in the bladder wall, kind of becoming hypersensitive or upregulated. The same thing can happen in our central nervous system and in the brain. The problem is that with the brain, not only does it perceive the signals it's receiving kind of in an exaggerated way, so 3 ounces might feel like 10 ounces, but it can send out signals in an exaggerated way. So now we have the brain sending out signals to the gut and to our muscles and to the vagina and to the brain and to the head. And we get what are called multiple pain disorders or chronic overlapping pain conditions. There's another smaller group within this phenotype, which is called central sensitization syndrome. Now, just like there's clues with the other phenotypes, there's clues that you may have a brain processing phenotype. I mentioned that oftentimes there's chronic overlapping pain conditions such as irritable bowel syndrome, fibromyalgia, migraines, vulvodynia, temporomandibular joint pain. Another group is called central sensitization syndrome. And with this, these individuals, they can be sensitive to lots of different environmental stimuli, smells, lights, foods, dyes, noises. Even just touching your skin can feel like pain when it's really just a light touch on your arm. When the brain has been revved up or the central nervous system has become hypersensitive, food sensitivity is oftentimes a problem. Oftentimes there's lots of allergies. Oftentimes there's emotional distress with anxiety and depression seen in this group. Um, there can be some symptoms similar to the bladder phenotype, and they've actually shown specifically with central sensitization syndrome in that smaller group that there is evidence of the C fibers becoming hypersensitive in the wall of the bladder. So there are physical changes seen in the bladder, sometimes with central sensitization syndrome and this phenotype. There is a tool called the Central Sensitization Inventory, the CSI. It's a questionnaire that can help you to screen to see if you have what seems to be central sensitization. Now, that questionnaire is available on my website, icjourneytowellness.com, and you just click on resources, and you'll find that questionnaire as well as some of the others that I'm going to be discussing. The role of the brain and the central nervous system is really an area of significant research right now. The good thing about the brain is that it has what's called neuroplasticity, which means not only can it change in a negative way to become more hypersensitive, but you can change it back in a positive way. Learning and using what are called physiological quieting methods is really critical. The use of, mindfulness, meditation, deep breathing, guided imagery, in addition to things like cognitive behavioral therapy, pain reprocessing therapy. These are all methods that have been shown to help turn down this hypersensitivity in the brain. Now, a multidisciplinary approach is really needed. A urologist all by themselves or a gynecologist all by themselves, they're not going to be able to tackle this. There's a lot to it. The MAP network has actually found that 44% of all IC and bladder pain syndrome patients had some type of chronic overlapping pain condition, irritable bowel, fibromyalgia, etc., which would imply that maybe the brain and the central nervous system is involved in up to 44% of IC patients. I think that this is a significant piece of the puzzle that we may not have been addressing, as we approach IC with our treatment plans. The main takeaway with this is that to get optimal relief of symptoms, all of the phenotypes have to be addressed. If you have a bladder-centric kind of phenotype, you need to address that. If you have a muscle phenotype, you need to address that. And if the brain has become hypersensitive, we need to address that. The research that's going on right now, as far as the brain and the central nervous system, I think is really a beacon of hope for the future as far as how we address all of, the person as a whole that has IC. Okay, so this is kind of the review. We started off with all of the IC patients, and then we broke it down into three sources of symptoms: the bladder and the urethra, outside the bladder, and the central nervous system or the brain. This group we call bladder-centric. And so this row right here is really what the AUA has described in their most recent updates on IC in 2022. Bladder-centric phenotypes, outside the bladder, which is primarily the biggest group, muscle and pelvic floor, and then the central brain and central nervous system. Now, Dr. Payne actually kind of described this row, the 5 phenotypes. And as we've learned more about the individual subgroups, I think it makes sense to have The bladder phenotype include urethral phenotype and infection phenotype because there are some unique differences in those smaller groups. And then we have the addition of the neuralgia phenotype as an outside the bladder because, again, the workup and the treatment is slightly different. So altogether, 7 phenotypes. 4 come from the bladder and the urethra, outside the bladder, and the brain. Okay? Now I'm going to take this at this point, kind of change gears. Okay, we're not going to talk about phenotypes anymore. What I want to address is what I call associated conditions. Now, associated conditions are things that happen to anybody. You do not have to have IC to have any of these. Okay, this can happen to anyone. The reason these are important is because the symptoms of these associated conditions oftentimes mimic IC. So you think you're doing everything for your IC, but really you have something else that's mimicking it or has very similar symptoms. And you're not going to get better until you address the associated condition as well. Some of these conditions are just more common in IC, or we see them quite often with IC. And some of them can actually sideline your journey to getting better if they're not addressed. And the one in particular, when I discuss that, is obstruction. So let's just go through these kind of one by one. First is endometriosis. Endometriosis is oftentimes called the evil twin to IC. Why? Because the symptoms are almost identical. Pain in the pelvis, urgency, frequency. You can have flares. You can have pain with intercourse, very similar to IC symptoms. Now, when I was in practice, I was in a group with 243 gynecologists. It was a huge gynecology practice. And there was one division, which was us, which was 2 or 3 urologists. So we were the urologist in this big sea of gynecologists. And I would see a lot of endometriosis patients that were treated, they were getting better, but they continued to have bladder symptoms. So they would get sent to me to see if they had IC. Similarly, I would have a lot of IC patients and they would be doing really well, but every month, like clockwork, the week before their period, they'd have a flare. And it would kind of go away on its own. The week after their period, it would kind of subside, but every month, like clockwork, it happened. And the problem that we found was that oftentimes endometriosis and IC, there was an overlap. There's been some studies that say that maybe 20% of the time when you see someone with endometriosis, they might also have IC and vice versa. So the point is that if you're having persistent symptoms, sometimes we need to investigate and see if maybe you have endo as well, okay? Vulvodynia, same thing. There's an overlap. Some people with IC also have vulvodynia or vulvar vestibulitis, which is pain kind of at the opening of the vagina or the vestibule, the entryway to the vagina. And it may be painful to wipe with tissue. It may be uncomfortable to wear, underwear or tight pants. The point is if you're having frequency, urgency, burning, pain in the vagina, pain in the urethra, sometimes it's not all the IC. You could also have vulvodynia or vulvar vestibulitis. And again, that needs to be addressed and treated appropriately. The ICA actually has some great information on their website about vulvodynia and vulvar vestibulitis. Now, recurrent urinary tract infections. Recurrent urinary tract infections can happen to anybody, young, old, female, male. Obviously, they happen more commonly in women because we have short little urethras compared to a man, but they can happen. Nobody wants to get a UTI, but you really don't want to get a bladder infection if you have IC because it can put you into a flare that can last weeks or even months. So to understand recurrent urinary tract infections, it just helps you to understand what keeps us from getting infections. So the things that keep us from getting infections are really, there's about 5 things. The first is hydration. We rinse the bladder. That's one of the ways that we keep ourselves from getting infection. I would always tell my patients, dilution is the solution to pollution. So rinsing the bladder is a good thing to do. We want to have a healthy lining to the bladder that's not sticky, okay? So because we don't want bacteria sticking to the surface of the bladder. We want to empty our bladder well. We want to have healthy bacteria living around the urethra. So if you're a female, you want to have good bacteria living around the opening of the urethra and not bad bacteria. And the other thing that keeps us from getting infections are what are called Tam-Horsfall proteins. These are little proteins that are made by the kidney, and they go down into the urine and they float around like little dust particles. But those dust particles will glom onto bacteria and stick to the bacteria, which then keeps the bacteria from sticking to you. Now, what happens with IC? Sometimes you don't hydrate, right? You don't drink enough fluids because you don't want to get up at night 5 times. You don't always empty the bladder, okay? You may have pelvic floor dysfunction. You may also have an enlarged prostate, a prolapsed bladder or a cystocele, some scar tissue. There's lots of, maybe you had an incontinence surgery that tightened you up a little bit too tight and you don't empty. Sometimes you don't have a healthy lining to the bladder. You saw that picture of the ulcer, okay? That red patch, that ulcer is going to act like a piece of Velcro and allow bacteria to stick. But there's other things that can also cause the bacteria to stick. Things like a polyp, a suture, a piece of mesh, a stone, a tumor. So there are things that can happen that can predispose you to getting infections. So the key thing with infections is if you're having them, is you need to be evaluated. Don't just go off and try the next thing online, because you could have a very significant physiological problem that's causing you to get those recurrent infections. So you really want to be evaluated, make sure you don't have a polyp or any other stone, etc., and then work with your provider to come up with a plan to help keep you from getting infections. The D-mannose that people use quite frequently is a sugar that we can't digest. It ends up in our urine and it floats around like a little particle, just like the proteins our kidneys make. And their purpose in life is to help glom onto the bacteria and keep them from sticking to you. But you still need to have a healthy lining, be emptying properly, etc. Okay. The next associated condition is genital urinary syndrome of menopause. Now, as a female, we all ultimately go into menopause, and there are certain things that will happen. Some of the symptoms of menopausal symptoms in the plumbing is urgency, frequency, burning with urination, pain with intercourse. Sometimes you're more prone to bladder infections, vaginal infections, etc. So a lot of the symptoms can be very similar to IC. If you're continuing to have burning, continuing to have urgency, it's possible that the menopausal issues need to be addressed as well. Treating the genital urinary syndrome of menopause does not always require estrogen. So if you have a concern about using estrogen, there are other things that can be used. So the point is that if you have this, it should also be addressed if you're not making forward progress with treating your IC. Okay, now voiding dysfunction. I'm almost done here. Voiding dysfunction is basically anything wrong with how you pee. Obstruction, you can't get it to come out properly. Maybe you're not emptying, it's too slow. Incontinence, you can't hold it in properly. You're leaking, cough, sneeze, urge, maybe even a post-void dribble where you pee, you wipe, and you walk away, and blip, out comes this little dribble for no rhyme or reason. Those are all forms of incontinence. And lastly is overactive bladder, which I kind of call gotta go, gotta go. Put the key in the door, gotta go. Step out in the cold, gotta go. Hear the water run, gotta go. These can cause symptoms that can sideline your progress or need to be treated differently than IC. So let's obstruction. Obstruction is something can happen from an enlarged prostate, a prolapsed bladder, scar tissue, pelvic floor dysfunction. The big thing with obstruction is the bladder is forced to squeeze much harder to push the urine through kind of the blockage. The pressure goes up in the bladder, and the bladder, which is a muscle, because it's working so hard, gets thicker and thicker. Kind of like a weightlifter who's been lifting weights. That's what the bladder's doing every single time you pee if you're obstructed. If you have obstruction, that's the one thing that I have seen sideline people the most where they don't get better with IC. You have to address that obstruction because the consequences of obstruction on an IC bladder is really felt. Similarly, the incontinence doesn't make the IC worse, but sometimes it's a clue. Overactive bladder, urgency, frequency. So maybe your pain is better, but you're still having frequency and urgency. The urgency of overactive bladder is what we call motor urgency. It's because the bladder muscle's giving a little squeeze. The urgency that you get with IC tends to be more of what we call sensory urgency. It's the sensory nerves that are making you feel like you have to pee. The question that I would always ask my patients is, if you were stuck in traffic and you couldn't go to the bathroom, are you more likely to get uncomfortable or pressure or pain, or are you going to feel like you're going to pee your pants? If the answer is I'm going to pee my pants, then it's more likely it's a motor urgency like overactive bladder. And this is where we use the meds, to kind of relax the bladder, like Myrbetriq or oxybutynin or ditropan, Detrol. There's a whole host of different meds. There's also non-drug treatments for overactive bladder. Um, including things like tibial nerve stimulation, which is like a little acupuncture in your ankle. Botox is used for overactive bladder, neuromodulation, etc. So there's a lot of overlap between the associated conditions and IC, but the treatments are different. Okay. So where do you start? We're going to start by looking at the clues. Gather your medical history, your surgical history, make a list of all of your past therapies and your response to them. If you're going in to see a doctor for the first time, bring in copies of any x-rays, testing, urodynamics, cystos, etc. Make a good list of your current medications, their dosages, and all of your supplements. And then get some objective hardcore data. Do a bladder diary. Highly, highly, highly recommend this. 1 day, 3 days is even better. You're going to measure what goes in, measure what comes out, what your capacity is, etc. All of this is actually available on my website, icjourneytowellness.com. There's free journal pages that you can download where you can collate all of this information, and it also has some food journals, bladder diaries, etc. What's the next step? You want to kind of assess for symptoms coming from outside the bladder. We use questionnaires for this, and I mentioned the questionnaires are on the website. The questionnaires can screen for pelvic floor dysfunction or pelvic prolapse, central sensitization, obstruction. Consider doing a food journal if you're food sensitive. Monitor your hydration. Don't, limit your fluids. Consider an elimination diet if you are food sensitive. Callie did an excellent webinar 2 months ago, and the ICA has a really good section on how to do an elimination diet. Everybody should learn how to do physiological quieting exercises, deep breathing, mindful meditation, stretches, guided imagery. Our watches have little breathing apps and mindfulness apps built into them. There's no reason not to do this. As a healthcare provider, we are medical detectives, and you need to become a medical detective too. By understanding how we think, you can actually help us help you. What we're doing is following the clues. We're asking questions, following the clues, and trying to come up with an idea of where you fit. What phenotype or subtype of IC do you have? Once we have an idea, we're going to use physical exam, perhaps some tests to help support the theory that we have or the hypothesis. I think this person has a bladder phenotype and a muscle phenotype. And then I'm going to use tools to kind of support that. Once I have a pretty good idea, then we come up with a treatment plan. Now, here's where past experience from past therapies is helpful. If you've already tried something, you might not want to try it again. Or if you've tried something and had a really bad side effect, it's important to know that. Sometimes we do combination therapy because there's more than one thing going on at once. So even though you tried a certain medicine once, you may still be asked to try it again in combination with something else. Some drugs work synergistically, kind of better together. So, but having that list will help your doctor come up with a plan that's going to make sense for you. Once you've got your plan, then we want to reassess and make sure we're doing the right thing, right? So oftentimes we'll have you do a bladder diary again and see if you've made progress. A 3-ounce bladder might become a 4-ounce bladder. You might not even notice a big difference, but we can tell that the bladder's getting bigger. In my experience with treating IC, pain and urgency often is the first thing to improve. Frequency and getting up at night is the last. And that's because the bladder just gets very small from peeing all the time. So once the urgency and pain is better, then we'll oftentimes start what's called bladder retraining. And here what we're doing is very slowly trying to stretch the bladder out to a more normal size, and you can do it. We have you kind of wait till the next batch of commercials or read 5 more pages in your book or do 3 more emails and then go to the bathroom, very slowly stretching the bladder out. The changes happen slowly, so you have to be patient. We sometimes use questionnaires to see if we're making progress, the scores are getting better. Just remember to be patient. And once you do get feeling really much, much better, don't sabotage yourself and go out and have 3 Starbucks, because you feel normal. Kind of add things back kind of gradually. I mentioned the questionnaires. Again, these are just tools that we use to help screen for other associated conditions. There's like the female and male genital urinary pain index. There's a pelvic floor questionnaire. There's an AUA symptom score, which is typically used for men with prostates, but we use it in women to check for obstruction. Again, all of these questionnaires and how you score them are on the website, icjourneytowellness.com, and you just click the resource tab. The bladder diary is there as well. So what are the key takeaways? The key takeaway is it's very common to have more than one phenotype, okay? In order to get optimal improvement, you have to address all of the phenotypes, okay? So if you have bladder, muscle, and brain, you have to do bladder, muscle, and brain. And the associated conditions, those other things that mimic IC, overactive bladder, menopause, we have to address those in parallel. That's going to get you to where you want to be. Okay. And I think that is a wrap. So I'm going to open it up to Janelle for questions, and I'm going to actually just stop sharing so that I can see everybody. Okay. Let me just, let me see, stop share. Let me go back here.
Great. Thank you so much. Yep, you can feel free to pop a question in the chat, or you can raise your hand and we will have you ask live.
I don't see anything in the chat quite yet. So I know I covered a lot of stuff. I didn't go over all of the different therapies for the different phenotypes because that was way outside of the scope of this. But hopefully everyone's understands that there are clear-cut smaller groups, and really we have learned a tremendous amount about those smaller groups. I think I have a shy group of people here today.
Anyone? Oh, I see that Jane has a question. Jane, feel free to unmute and ask your question. I don't know if Jane heard me, so I'm going to pop over to the chat real quick. We have some questions. The first one is, can you comment on current research being done for IC?
Right. So I alluded to a lot of the research at the beginning. So the MAP network, and there is that website, www.mapnetwork.org. You can go through, there's dozens and dozens and dozens of publications. A lot of the research is starting to look at the smaller groups, trying to understand what's the root cause, for example, of a infection phenotype, or what do we know about ulcerative IC? The AUA guidelines, which you can get also online, goes through a lot of the current research. So again, the focus is not so much on the bladder anymore. We recognize that there's a lot of things wrong with the bladder, but the focus is more on understanding the smaller groups. For example, the hypersensitivity of the nerve endings. What triggers that hypersensitivity of the nerve endings in the wall of the bladder? Is it the mast cells? Are there other inflammatory, mediators? So there's no one research. There's a lot of research being done in a lot of different areas, a huge amount of research on the brain and central nervous system and its role in the whole picture. Okay.
I have a question. Can you see me or hear me?
Yep, I can see you.
Okay, yes. I wanted to ask you, I have one doctor who has put, he's a dermatologist, and I have itching from fibromyalgia. And he has me on quercetin with bromelain. And I looked that up and I saw that can possibly cause you'd have kidney and liver disease if you're on it for any length of time, for which I've been on it for quite a length of time. And I never found that any of these things, I don't want to say hokey pokey things, but all these vitamin things, the zinc, this, I mean, I'm taking like 10 different medications from this one person. And I just don't want to be on something that's going to potentially, and we never know potentially, but I unfortunately was one of the patients that ended up with BPS maculopathy from taking Elmeron. So
Yeah.
yeah, very unfortunate. And
Yeah. So it's a hard question because, you know, the side effects from medications is dose dependent. So, sometimes a normal dose or a acceptable dose of, for example, quercetin has been used quite commonly with IC. It's an anti-inflammatory. It's available, it doesn't require a prescription. It's felt to be generally relatively safe. But again, it all depends on the dose. And it also depends, even with the supplements, on your other, health conditions. Some people, shouldn't take, for example, certain medications because their kidneys don't work perfectly or their liver doesn't work perfectly or because they're diabetic. And so it all depends on all of the other stuff you're taking, the dosage that you're taking. But in general, quercetin, I don't know as much about the bromelain, but the quercetin is an anti-inflammatory. It's felt to, it's a natural kind of bioflavonoid that's felt to not have significant side effects. But I can't comment specifically on your case because I don't know all the other stuff you're taking and your
I
history.
understand.
Yeah.
Unfortunately, I am on an array of medications. It's 800 mg of quercetin, and bromelain is 165. And I took myself off of it after reading that article because of what the Elmeron had done to my eyes. And you're familiar with that.
Yep. Yep.
There you are.
Yeah,
And
so I think probably, the best thing with any of these things is to discuss it with your physician, the one who's recommending it. And sometimes, it's also a good idea to get a second opinion from another physician, because a lot of these things we don't have the answers to. And whereas one person may have a certain, may have been trying certain things, if it's not really helping, I think across the board, if things are not felt to be helping, then you should reassess whether or not it makes sense to stay on it. I
that's what I
usually
was
don't
saying.
recommend discontinuing things without talking to your doctors, because, sometimes those things are important for a variety of different reasons. Not so much with supplements, but with, in general, you don't you need to do things with your provider, as a team.
I do. And I
Yeah,
told
as a
him I was
team.
going off, told him why. And he said, that's fine. And then I got back on it again because I figured, well, nothing's working. But the thing I wanted to also ask you, there's something maybe you incorporated this, but Librex to relax the lower abdominal muscles. Is that actually a relaxer for
Yeah.
patients?
So Librex is basically like Librium, which is kind of in the Valium kind of family. It's called a skeletal muscle relaxer. So we have two different kinds of muscles in our body. Skeletal muscles are the ones that we can consciously squeeze, like our arms, our legs, our back, our pelvic muscles. Those are all skeletal muscles. The bladder, the heart, the gut, okay, the inside sphincter of our urethra, those are smooth muscles. They're innervated by different nerves. So the Librax or the Valium or the Baclofen, those are all going to relax skeletal muscles, the pelvic floor, the abdominal muscles, things like that. Um, the smooth muscle relaxers are different. Okay, and I'm pretty sure Librex is Librium, but I'd have to actually look it up. It could be hyoscyamine. Hyoscyamine is let me just sometimes the
It's
brand
chlora hydro. I can go get it real quick while you're talking
I'm
to
I'm
someone
I'm
else.
doing a quick Google on it.
Want me to
But
go look?
anyways, so
Uh,
the so the if There is a smooth muscle relaxer, which is
Yes.
hyoscyamine, and that doesn't relax your abdominal muscles. It relaxes the bladder. Okay, so if you have urgency or if you're having, abdominal cramps, like IBS cramps,
Yes.
that's and actually I'm thinking Librex might be more along those lines.
Thank you.
So
Great.
again, if you're not sure, just ask the doctor who's prescribing it or even your pharmacist. But there are two different kinds of muscle relaxers, skeletal muscle and smooth muscle relaxers.
Thank
Okay.
you for your help.
Thank you. Okay, our next question is, can vitamins cause a flare-up, especially if it has vitamin C in it?
Yes.
Okay.
So the B complex vitamins, okay, we typically don't like for overactive bladder symptoms, and because they can create kind of more bladder spasms and urgency. And in IC, a lot of the B complex vitamins will do the same thing. Vitamins that can, like vitamin C, can sometimes make your urine more acidic. And um, if you have a bladder source of symptoms, or if you have ulcers in your bladder, especially, if the urine becomes very acidic, you feel it. Okay. It's almost like having a canker sore and putting vinegar on that canker sore. You feel the acidity on the sore. Now, someone who has more of a muscle phenotype, okay, a phenotype which is coming from outside the bladder, where the lining of their bladder is okay, they may not have any problem with vitamins. Okay. So it really kind of depends on where you fit in. If we think you have a bladder source of symptoms, ulcers, urethral phenotype, infection phenotype, clearly, you're food sensitive, if you put an anesthesia in, it feels a little better for a short time. Those are all clues that the bladder itself may be the source of symptoms. Then things like the vitamins and changing the pH of the urine to be more acidic, you're gonna notice. So the flip side would be you might notice that using pre-leaf, making your urine less acidic helps you. But the B complex ones in particular are the ones that I would always steer away from.
Thank you. Next question. Can one have more than one phenotype? I seem to fit in more than one.
Yeah, I would say absolutely. So there was actually a study done by Dr. Nickel, who described uh, the U point phenotypes, and he found that the majority of people did have more than one phenotype. Some of them, and I can actually get the statistics, but the it's very common to have more than one. The ones that tend to the one group that sometimes only has one phenotype is sometimes the ulcerative IC patients only have an ulcerative IC phenotype, and they don't have any evidence of pelvic floor dysfunction or a muscle phenotype, and they may not have. And they've shown that they don't tend to have as many of those chronic overlapping pain conditions. So some ulcerative IC patients only have ulcerative IC. But most of the other, it's very common for other patients to have more than one phenotype. I think the longer you've had IC, the more likely it is that you may end up with more than one phenotype as well. So for example, if you start off with, say, an infection phenotype and you're having that hypersensitivity over time from kind of constantly holding your urine, you might then develop a pelvic floor dysfunction. And then because you have these pain signals bombarding the brain for 10 years, pretty soon your brain gets revved up as well. So now you went from one to, just a infection phenotype to an infection and a muscle phenotype to a muscle, a infection, a muscle, and a brain phenotype. So we don't know yet what the natural history is, but we do know the correlations between some of these. So very, very common to have more than one. And the key is to get better, you have to address all of them. Okay.
Thank you for that. Next question. What do you make of the question of viral load, Epstein-Barr, etc.? Does that fall into the infection phenotype?
Um, so there's been some studies, viruses may actually contribute to the ulcerative IC. There's been polyoma viruses. They have been looking for a bacteria or a virus that causes IC for the longest period, I mean, for a long, long time. Even when we were talking about IC way back in the 80s, there was always felt that there must be something, kind of like if you think about it, ulcers. People who were stressed got ulcers. People who had too much acid in their stomach got ulcers. And everyone was, treating it a certain way. And then pretty soon, oh, they found H. pylori was, the bacteria that caused ulcers. We've always been hoping that we would find something like that, and it hasn't been found yet. Okay, does that mean they'll never find it? To date, they haven't been able to pin it on Epstein-Barr or polyomavirus or any other virus or bacteria. There's even been thoughts that maybe it's a fragment of a bacteria. And you'll hear people say about the biofilm and kind of cryptic type, like just a segment of a bacteria, like a little genetic, piece of a bacteria might cause it. We've never been able to prove it. But there's always a little bit of research that kind of says, ooh, in this group of people we saw 10 people with Epstein-Barr, or 10 people with polyomavirus. There's nothing clear that supports that as the cause of IC. But there's still, it hasn't been written off. Let's put it that way.
Okay, thank you. Next question. Is there anything to high potassium possibly impacting flare-ups?
Well, high potassium in the urine, I would say yes. I mean, they came up with the potassium sensitivity test where you could instill, you basically would put just plain old saline or salt water in the bladder, and you would record how much urgency you had and how much pain you had. And then they would put a potassium solution in the bladder. What potassium does is it causes nerve endings to fire, kind of in a negative way, like cause horrible pain and urgency. And so if you had IC, the idea was you would put the potassium in the bladder, you'd have all this horrible pain and urgency, and then they would do this rescue solution to kind of help, get the symptoms to go away. I personally never did that test because the idea of creating horrible pain in somebody who already had symptoms just didn't make sense. And but the thinking was it could help show if you had a gag layer problem or if you had a C fiber nerve problem in the wall of the bladder. And so, yes, I suppose if you're sensitive to high potassium foods, and there's high potassium in your urine, it could trigger symptoms if you have a bladder kind of phenotype. So, the potassium sensitivity test would infer that would be the case.
Thank you. Next question. I'm a patient with Hunner's ulcers, PFD, vulvodynia, vulvar vestibulitis, and ulcerative colitis. I'm taking 25 milligrams of cyclosporin 2 times a day. What is your experience with cyclosporin TX?
Yeah. So basically people with Hunner's ulcers, that's a unique phenotype. The pelvic floor dysfunction would be a muscle phenotype, which commonly can go along with it because you're having that pain and urgency and you tighten up your muscles. And then with the vulvodynia and the well, not so much ulcerative colitis, but with the vulvodynia, fibromyalgia, those symptoms, that would infer that the brain itself has become hypersensitive as well. Okay. So clearly sounds like at least three phenotypes. Now, the treatment algorithm for ulcerative IC, and this is in the AUA guidelines and pretty accepted across the world, is that you treat the ulcers with what's called fulguration, which is kind of burning the ulcer. And you can do it with cautery, which is most commonly done. Some people have used laser. And then you can inject a steroid into where the ulcer was. It's called triamcinolone. You can do one or the other or both. I typically would do both. Okay. I would fulgurate it and then inject the steroid. I had a few patients that didn't want to keep going back to the OR for the fulguration. So they actually wanted to have the injection of the steroid in the office. So we would numb them up like we were doing a Botox, and then I would inject the ulcers with the steroid in the office. And that was their preference. Now, the cyclosporin is specifically, since it's an immunosuppressant that kind of turns the immune system down. And the people who have the most experience with cyclosporin are transplant doctors. So they use this in transplants all the time to keep people from rejecting a transplant. And you do have to be monitored for, kidney function, blood pressure, things like that. But a lower dose has been shown to be very effective, specifically in the Hunter's ulcer groups. And so that's the only group that I've ever used it for. Okay, we don't use it across the board for all IC patients. The research has shown that it's a good treatment for ulcerative IC.
Great. Thank you. Next question is, can you address the role of prolonged toxic mold exposure in causing IC? I have had 2 doctors tell me that could have caused mine.
Oh, I don't have an answer for that one. I don't recall reading any articles specifically on prolonged toxic mold exposure. So I don't know. I don't have an answer. If there could be an article out there and I just haven't seen it. There's a lot of research done, and there's sometimes that kind of article might be in a publication that's not, something that I would see. My background, in undergrad, I was a microbiology major, so I kind of like bacteria and molds and funguses and viruses. I mean, that's what I studied before I went to medical school. Um, Sometimes we know with molds, I'm just kind of thinking outside, it can trigger allergic reactions, right? And, you get runny nose and watery eyes and all kinds of symptoms from allergies to molds. So if and again, this is not based on anything I've read or any research. I'm just kind of trying to make sense out of it. So if you were exposed to toxic mold and you developed severe allergies, okay, we do know that when you have severe allergies, oftentimes the mast cells, which are one of our allergy cells, or the eosinophils, which is another allergy cell, they can be, triggered to release histamine. And when the mast cells dump their histamine, they also release what are called cytokines, which are little molecules that allow one cell to talk to the next. So think of the mast cell dumps the histamine in response to an allergic reaction of some kind, and then that triggers, nerve growth factor to cause you to get more C fibers, et cetera, et cetera. It's kind of like this cascade of events. So the only thing I could say, and I do not know of any paper that says toxic mold causes IC, but I would guess there's some article that says toxic mold could cause allergies. And if that's what happened, severe allergies could have triggered mast cell activation. And we do know that mast cell activation is part of the cascade for some people with IC. That's why people take antihistamines and use medicines to stabilize the mast cells. Okay.
Mm.
That's the only way. That's how I would make sense out of that.
Yeah. Interesting. Thank you. Next question. Do you find that many physicians refer IC patients to pain management practices? As a support group facilitator, it seems women with IC pain are not being treated effectively for ongoing high levels of pain.
Yeah. I have, and I do think more and more doctors are I think the best way to deal with IC and bladder pain syndrome is in a multidisciplinary fashion. There's a role for the urologist, there's a role for the gynecologist, there's role for the urogynes, there's role for physical therapy, dietitians, neurology sometimes. Pain management is a part of that multidisciplinary team, and psychotherapy, etc. We have to pull all the tools out of our toolboxes to come up with something. And I think having a plan in place for pain helps to alleviate some of that anxiety. Because when do you get a flare? It's at night, it's on the weekend, it's right before your kid's recital, it's right before you have an interview. I mean, it's always at the worst possible time. And if you have a plan in place, some of that anxiety goes away. So I do think it's worth, utilizing pain management, somebody who understands it. And some pain management teams don't want IC patients because they don't need, nerve blocks, and they don't need the stuff that they like to do. They just need management. But a good pain management group will have practitioners that can help with medical management, kind of help with synergistic therapies. So, for example, instead of just using narcotics, and we're not talking about pain management always being narcotics, it could be combining a lower dose narcotic with something like a gabapentin. We've used medical marijuana, we've used low dose naltrexone, topical analgesics, coping and psychotherapy to help with coming up with a good coping skills is part of pain management. So I do think pain management needs to be included in the mix, because more and more doctors, they're not versed in it. I mean, we know it as surgeons because we operate on people, we have to deal with their pain, but dealing with acute pain is different than dealing with chronic pain.
Thank you. Next question. Any treatment suggestions for patients with severe urethral pain? Pudendal blocks do not work.
Okay. So if the pudendal block is how we diagnose pudendal neuralgia, okay? So the fact that the pudendal blocks isn't working is telling us that it's probably not pudendal neuralgia, okay? And it's probably more of a urethral phenotype, okay, which is different. It's a different phenotype. Now, the big thing with urethral phenotype is if the pain is focused on the urethra, you have to make sure that the differential diagnosis of all the things that can cause urethral burning has been gone through. And a common thing that I have seen be missed is what's called a urethral diverticulum. The urethra in a female is about the length of my pinky. It's about 3 centimeters long, and it has about 20 different pairs of what are called periurethral glands, or like the little pores on your nose. Okay. Sometimes those periurethral glands can get clogged up and they form like a little cyst. Think of like a pimple that has to drain, okay, or a boil. That cyst becomes it drains, but then it develops this little pocket or this bubble, which is connected to your urethra. So now every single time you pee, urine goes and fills up that bubble, that diverticulum. The symptoms of a diverticulum are what we call the 3Ds: dysuria, which is burning, dyspareunia, which is pain with intercourse, and a post-void dribble. When I mentioned that some people will pee, wipe, walk away, and then blip, a little drip of urine will come out after the fact, that's a good clue that you could have a diverticulum. Now, not all diverticulums will do that, but many do. A diverticulum is very hard to see. You can look in the urethra and all you're seeing are the little pinholes that go to those glands. You don't know that one of those pinholes goes to a bubble. So it can be missed on cystoscopy. If you examine a person and the bubble has drained, there's nothing to feel on a pelvic exam, but the symptoms are terrible burning with urination. So if you are female and you have persistent urethral burning, sometimes, you may want to just ask your doctor, is it possible I could have this? Have you checked me for that? The way they check you for it is usually an X-ray, a pelvic urethral MRI, or what's called a VCUG, where they put a tiny little catheter in and then they have you pee while they watch and see if a little bubble fills up. The treatment is to remove that bubble and all the symptoms go away. So urethral pain, you want to make sure you've gone through the list. It's not a urethritis, it's not a stricture, it's not a urethral diverticulum. Assuming it's not any of those things, you have to make sure you don't have vulvodynia, okay, because a lot of the symptoms of vulvodynia kind of overlap with urethral phenotype. And I have always found that a high oxalate diet, too much spinach, nuts, things like that, that create crystals. It's like you're peeing out little shards of sand every time you pee. So with urethral symptoms, you want to make sure that your urine is not too concentrated because you don't want to be getting crystals that you're voiding and making like little paper cuts up and down the urethra every time you go. I don't know if I answered the question or if I got off on a tangent.
No, that was great. Thank you.
Okay,
Um,
so,
yep. So it looks like we have maybe three more,
okay.
if you're okay.
Yep.
The next question is, how can you tell IC from IBS?
Oh, from IBS.
Mm-hmm.
Okay, so IC is kind of suprapubic kind of pain or pressure or discomfort that is felt to be coming from the bladder. Okay, so typically it's like as your bladder gets fuller, 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 you get more and more symptoms. That's not uncommon. And when you urinate, it tends to relieve the symptom. Okay, um, uh, so it's sometimes associated with more frequent urination and oftentimes associated with a sense of urge, but not necessarily like I'm going to pee my pants urge. But there's urinary symptoms, lower urinary tract symptoms that tend to go away with it. Irritable bowel syndrome is kind of the same thing, but you feel like the symptoms are coming from your gut. So, you pass some gas or you move your bowels and you kind of feel a little bit better. You may the perception of where your symptoms are coming from tends to be more gut related. It may be I guess that's the best way. If you're not sure if it's bladder or not, again, you can just do a simple diary. If with IBS and if it's gut type pain, your bladder should be working pretty normally. You should be able to hold, 8, 10, 12 ounces in your bladder. Um, that would be a pretty good clue that it's maybe not your bladder and it is your gut.
Thank you. Next question. Can endometriosis come back with vaginal estrogen?
I would say most likely no. I'm not a gynecologist, I'm a plumber. But like I said, I was in a group with 243 gynecologists. So I lived amongst the gynecologists. Um, when we use vaginal estrogen, especially normal doses, like a tiny little, Vagifem tablet or a topical amount on your fingertip, systemically, there's no increase in the amount of estrogen in your blood. And that's why many patients that have a history of breast cancer, when they check in with their oncologist, the oncologist is okay with them using a small amount of topical estrogen because there is no change in the blood levels of estrogen and they've done tests to measure whether or not there's a change. So I don't think endometriosis is going to come back if there's no measurable change in estrogen in your blood. Okay, because endometriosis is linked more to the systemic blood levels of estrogen, not what we would get from a tiny bit of a vaginal topical estrogen. But that would be a question I would probably ask your gynecologist, and they may have the literature to support what I just said. But I'm just kind of going with, you know, what I know about the blood levels of estrogen based on topical treatment. Okay.
Great. Thank you. And then there's just two more. The patient with Hunner's ulcers, PFD, vulvodynia, vulvar vestibulitis, and ulcerative colitis is asking about um, the 25 milligrams of cyclosporin. I cannot remember if you already addressed that one.
Did that
But
one.
then okay, and then the other question was, in addition to that, I have had a hydrodistension um, with bilaterally Kenalog injections. I don't know if I'm saying
Yep,
that
yep.
right, multiple times, and have also taken nortriptyline, urel, and hydroxyzine, um, and interstem bilaterally. So
Wow.
I don't, I'm not sure. I think she was just letting us know that those were her
Yeah.
treatments.
Yeah. So all of those things are, so the hydroxyzine is used to block the mast cells, and we know that mast cells can be present with the Hunner's ulcers. The the neuromodulation, which is the inner stim, that is used in, and I've had some patients where that has helped them to be able to hold a larger capacity. You know, the the symptoms, it all, at the end of the day, it boils down to the bladder. How big is the bladder? How much can the bladder hold? Some people, the bladder just gets smaller and smaller and smaller and thicker and thicker and thicker, to the point that you can't physically get it to hold much more than an ounce or two. And so you do all of these things, and you still just can't get it to change, even with Botox, things like that. And I've had some patients over time that the pressure in the bladder just gets to be so great, because it's so thick and it just doesn't stretch anymore, that it was actually pushing the urine up into their kidneys, and they were starting to go into kidney failure, etc. So there are some people with Hunter's ulcers in particular that do end up going to the last step of the roadmap that we have, which is to actually have the bladder removed, or even sometimes we leave the bladder in and we just divert the urine away from the bladder, because the bladder as a bucket is just no longer a good bladder to store the urine. So the goal of the bladder is store enough urine so that you can function. You're not peeing every 5 minutes and you're not leaking all the time, and keep the pressures low enough so that the urine doesn't back up into your kidneys and cause kidney damage. So if everything has been done and that can't be accomplished, that's the group of people who have the best luck with surgery. Now, if you have other brain phenotype things going on, vulvodynia, fibromyalgia, all of that stuff, sometimes you can still have pain, even though the urine's sent somewhere else. And that's the clinker. No one can ever guarantee that you're going to feel perfect after a surgery. Some people have phantom pain, even though the bladder's gone. The brain keeps sending signals like, oh my God, I have to go pee, and there's not even a bladder there. So a surgery is the very last resort. When we've done it, it's usually been because the consequences of what the bladder was doing to the kidneys, etc., was at a point where we really had no other choice. I think I saw a question there as to when do you do a cystectomy?
Yep. And that's gonna be our last one. You've been so generous with your time. Yeah, what's the role of cystectomy in terms of so many phenotypes?
Yeah, so again, the one phenotype where we typically talk about cystectomy is the ulcerative phenotype. And most of the other people, I can tell you that they don't get to that point. The bladder, if the source of symptoms is from outside the bladder itself is actually okay. It can, we want a bucket that can hold an acceptable amount of water so that you can live, and not pee off every 5 minutes. And we want the pressure in the bladder to be normal, because if the pressure goes above the magic number's 40, it'll push the urine up into your kidneys and you'll start getting kidney failure. So we don't want that. And we can usually accomplish these things in almost every phenotype, but not always in the ulcerative IC phenotype. So if you you know, again, with Botox, we can relax the muscle and make it not so tense. With neuromodulation, we can change the way the nerve signals are going to the pelvic floor and going to the pudendal nerve and going to the bladder. And we can solve a lot of symptoms with some of the more advanced therapies that we have, the neuromodulation, the Botox, things like that. With ulcerative IC, sometimes the bladder wall just becomes what we call fibrotic. It gets so scarred and so thick that, you have this bladder. Think of like trying to blow up a balloon that's nice and elastic. Whoosh, you can blow it up and make a great, perfect balloon. If you have a balloon that's made out of half-inch thick leather, there's like no way you can blow up that balloon. I mean, you'd have to use like a massive like tire pump, like a tire to try, so much pressure to try to get it to stretch. So if you get a bladder that's like that, very thick, very fibrotic, sometimes there's nothing, no medicine, no treatment that's going to change it. And that's the scenario where cystectomy, or sometimes you just opt to leave the bladder there and just divert the urine and make a new bucket out of bowel that can store the urine and keep the pressures in the kidney low and have you have a socially acceptable, amount of time before you have to go to the bathroom. Sometimes you have to use a catheter to empty, or sometimes you have a bag, but life is good. I mean, you don't have all the other symptoms.
Wow, thank you so much for all the extra time and for being with us here today, Dr. Petersky. Today's session was so informative and you've been so generous. And just so you know, in addition to all the questions, you received some wonderful messages about how grateful people are for all of
Oh,
your
thank you.
knowledge and how
Well,
easy it was to digest.
good. So again, if you go to my website, you can get the journal pages to just put together all your stuff in one place. The questionnaires are there, and you can find out more information. I have a blog and stuff like that that kind of goes over some of this stuff. But it's a lot to digest. But
Yeah.
thank you for allowing me to talk to you today. I really had a fun time.
No, wonderful. Yep, we all enjoyed, and I know we all learned something new. For everyone who attended, if you found this event to be of value, please consider joining us for future webinars and please share these opportunities with your community. We also would like for you to mark your calendar for April 25th. That's our next webinar, and it's titled Breaking the Silence, talking about suicidality. And our speaker will be Christy Ninneman. She's an ICA Medical Advisory Council member, and this webinar will be free of charge. And the link is in the chat and on the ICA website. And then real quick before we go, we have an exciting announcement. You may have heard that we are celebrating our 40th anniversary year. So we are marking 40 years together. So if you would like to join us, you can get involved in many different ways. You can set up a fundraiser, you can donate, you can spread the word on social media. And we invite you to just keep an eye on your inbox from ICA emails, follow us, and participate in our activities. So we want to thank you for joining us today and hope you have a good rest of the week.
Thank you.
Thank you.